Tonight's talk is around the trunk because over the years, it's become apparent that there's a lot of discussion around the role of the trunk in movement and to a certain extent, a preoccupation with training muscles of the trunk. And so I thought it might be worthwhile to consider the biomechanics, what the muscles of the trunk can and can't do, and what the implications of those things are for analysis and intervention. But before I begin, I would like to acknowledge the peoples of the area from where I'm presenting, who are the Darkinjung and Gurungai people. We're just a little bit north of Sydney, as Annie was saying, and I acknowledge their elders, past, present and emerging. And we acknowledge also that the lands on which we are living at the moment have not been ceded by the Aboriginal people. So, the biomechanics of the trunk. What are the implications for analysis for sitting, measurement, trunk research, the underlying assumptions, and the interpretation of those results have very much to do with understanding the biomechanics of how the trunk works and what we can then learn about intervention decisions and how we might go about interpreting the results of research papers that are published that perhaps don't fit with those underlying knowledge of biomechanics. So the key messages out of this talk are that we need to understand the biomechanics of whatever skill or task we are training. And this is an important aspect of our role as clinicians, is to really understand the fundamental biomechanics of the task and skills that we're training. The essential role for the trunk is primarily to keep us alive. The trunk is structured in such a way that we have all of our essential and vital organs that are contained within the trunk. And we'll come back to this issue around what the essential role of the trunk is, but it's primarily to keep us alive. And to this end, in terms of evolution, and as Simone described last week, our trunk muscles are bilaterally innervated. So for people following stroke, for example, where they may have a unilateral lesion, the trunk muscles are essentially protected from that stroke, unlike the limbs. So perhaps we don't need to really be so concerned about muscles of the trunk when we're looking at the problems that people have after a stroke. The upright balance of the trunk is dependent upon the strength and the coordination of the muscles at the base of support. And we need to be careful when we're analysing as to why the trunk is falling in a particular direction, and be aware of the fact that the muscles within the trunk are unable to actually affect the position of the trunk relative to the base of support. And so in sitting, it's the thighs and the feet. And the first muscles in standing that are initiated to control the movement of our centre of mass is once again at the base of support, and that's the feet. And leading on from this, our analysis and intervention strategies really need to focus on the essential components of skills such as sitting and standing, particularly for people following brain injury, where the intervention strategies that we need to target need to be specific to what their needs are and how we go about analysing the kinematic deviations and also the muscles that are weak, perhaps, or poorly coordinated. So to begin this session, I'd like to start with a man who's having profound difficulties sitting. This man's been asked to sit on the edge of a plinth. He's sitting on a height of a plinth where both his feet can touch the floor, and there's a person behind him trying to help him sit. And while you're watching this video, I'd like you to think about, well, where might I start with this man? Where are the main problems that he has with sitting? So while you're watching, you can see that he really does have profound difficulties remaining upright, and he finds it impossible at the moment to control the movement of his trunk forwards and sideways. So the question that we can ask ourselves as clinicians is, well, where would I start with this man in terms of analysing what his problems are? And underlying that, where would you start is, well, why would I start there? What are the underlying rationales for why I would start there? And then how would I go about prioritising the problems so that this man can be successful at sitting? So here's a possible way that you might want to organise your ideas, that you see an observed problem, that is, this man can't keep his trunk upright. He's falling to his left and he's falling forwards. What's the possible cause of that? And then what would you prioritise in relationship to those problems? So where would you start and what's the reasons for that? So if we watch again, with those questions in mind, if you have a sheet of paper, you can write down what your rationales would be. But we can see that this man is really having profound difficulties even listening to what's being said to him. He's being asked to put his hand on his thigh. But the moment that the person lets him go, the therapist lets him go, she's now trying to ask him to stay upright, but he's unable to do that at all and still falls to his left. So this man's in a profoundly difficult situation. He really doesn't have any brain space, any potential to listen to what's being said, because all he's doing is really falling. So he's falling to the left and he's falling forwards. He's pushing to the left with his right hand. He really doesn't like being in that upright position. And his left foot certainly doesn't ever really rest firmly on the ground. So from these sort of observed problems or kinematic deviations from what we would normally expect to see, why might this be happening? So if we start with the falling to the left and forwards, does he have poor trunk control? And if it's muscles within the trunk, then which muscles within the trunk would you target to help him learn to be able to sit? Is it problems with his inability to push on his left leg? Is it a problem of strength in terms of his left leg extensors, perhaps at the hip, the knee, or the ankle? He also falls to the side. So does that also reflect a problem with strength in the abilities of his left hip abductors and adductors to control his pelvis as he falls across to that side? Pushing to the left with his right hand when he's brought to the upright position. Perhaps he has an altered sense of verticality, and what might we do about that in terms of him learning to be upright again? His left foot's not on the ground, as we had noted, so perhaps he has this, it relates to a decrease in sensation in his left leg, perhaps a lack of proprioception in addition to touch. Or perhaps it relates back to the reasons that he's falling to the left and forwards, and that he doesn't have extensor strength to be able to push down on his foot to stay upright. So any one of these things we can then start to drill down and work out, perhaps if it's the trunk, which muscles, if it's the leg, which muscles, and so on. So I might just stop there quickly and see if there's any questions in the Q&A before I continue.
There's nothing there, Karl.
All right, we'll keep those questions in mind. And if you want to ask questions, please don't hesitate while the talk is on. And well, there's a number of times through this talk when there'll be opportunities for questions and answers. So if we return now to this idea of biomechanics, and biomechanics is really the study of forces and the effects of those forces on and within the body. So it's made up of the things that we see, the kinematics. And in this case, we see a man who's falling to his left and to the side, can't keep his left foot on the ground. He doesn't like remaining upright. So there's certain forces that he's unable to generate to stop gravity from pulling him forwards and to his left. So there's an absence of force somewhere that stops him from being able to sit. And so the one thing that we all know while we're alive is that to be able to move anywhere, gravity is the ongoing determinant of the muscle activity that's required for us to move from one place to another, to be able to remain upright, to be able to reach with our hands for a glass of coffee or a cup of coffee, or to be able to do all of the things that we need to do. Fundamentally, we need to overcome gravity. So there are certain demands that gravity places upon us. And obviously, for this man attempting to sit, he's unable to resist the demands of gravity and is falling. So the biomechanics of the trunk, what do we know? Well, the trunk, as in English, has many meanings for trunk. But the trunk that we're talking about is our physical trunk. So what is it? The definition that I'm using is the torso. That's the part of the body to which the head and the limbs are attached. It includes our chest and abdomen and back, and comprises a skeleton, connective tissue, muscles, and as I was saying before, the vital organs that actually help keep us alive. So here's a trunk with everything stripped away, just the skeletal system. And here's a trunk with everything included. And we're now going to go through these section by section and have a think about what they do. So if we consider the vertebral column first, it's a stable relationship of closely articulating vertebrae. They're attached by intervertebral discs, ligaments, and connective tissue. This vertebral column provides protection for the spinal cord. It allows exit points for those nerves to then communicate with vital organs, with our muscles, and also sensory information back to our cortex. And importantly, it provides spinous processes for muscles to attach. So we have the intervertebral muscles, the little muscles that attach from one vertebra to the next. We have rhomboids, trapezius, latissimus, and dorsi, and so on for our shoulders. So there's muscles that are external to the trunk that attach to the trunk. At the hip, we have psoas, which is attaches to the transverse processes of a lumbar spine, which is the one muscle from our trunk that actually has a crossing of the hip. And now we can add in the ribs. And so now we have a structure that sits around our heart and our lungs to protect them, and also combines with the actions of the diaphragm and the intercostal muscles for the negative and positive pressures that we have to be able to breathe. And then on the bottom of this, we have a pelvis. So this physically just helps to contain the contents of the trunk. If we then add in the ligamentous tissue, it provides a very large surface area for the attachment of muscles. So the trunk muscles, the abdominals, the pelvic floor, quadratus lumborum, trunk extensors. But importantly, it also provides attachment for a very large number of big muscles in the legs: glute maximus, medius, minimus, iliacus, biceps femoris, rectus femoris, and so on, adductors and abductors. And also it provides the attachment for latissimus dorsi up to the shoulder. So the pelvis provides a very large structure for attachment of very large muscles. So to summarize so far, the trunk is fundamentally stable in terms of the skeletal system. It's stable vertically, stable horizontally. It allows some movement, but it doesn't allow a lot of movement, because it needs to protect our vital organs. Because if we just bent all over the place, then perhaps we would damage our tissues. And provides attachment of muscles, trunk, leg, and arms. So here's the protective system, our vital organs, spinal cord, heart, lungs, digestive system, liver, kidneys, and so on. So let's just have a think about how much your trunk actually does move passively. What I'm going to ask you to each do now is to allow your trunks to gently sag, not your hip to flex, so not hip flexion, but allow your trunk to flex with gravity, just pulling you down into flexion. So it's not neck flexion, trunk flexion. And think about how much your trunk actually flexes. And now do the same for extension. In this case, you're going to just keep your neck in a kind of gentle position and see how far you're actually able to passively allow your trunk to extend. So it's not neck extension, it's trunk extension. How far can you move? Now try for side flexion. So try to keep your weight evenly on each ischial tuberosity and allow your trunk to side flex. Now allow your trunk to side flex the other way. Rotation is a little bit harder in sitting to do passively, but see how far you can rotate. Very gently and gently to the other side. So we have some movement in all of those directions, but it's not excessive. And it has a limitation in terms of how far we can go. Unlike the range of motion we have at an elbow or a knee or a hip, the movements that are contained within the trunk aren't large. So it's essentially a stable structure. Are there any questions so far?
No questions, Karl.
I shall push on, but maybe the questions will arise as we keep going. If we now start thinking about the muscles. So if we take the anterior trunk first, we can add in the diaphragm, and then the intercostal muscles that are to allow for breathing, as well as quadratus lumborum. So we're starting to build a structure around those vital organs. We then add in the vital organs. And then over the top of this, we have this very beautiful sheets of muscle tissue that then combine to contain these contents. So we have transversus abdominis, rectus abdominis, internal obliques, and the external obliques. So now I have this very beautiful packaging of sheets of muscle to help contain those contents within this structure. If we go to the back, here we have the trunk with the first layer of muscles. So we have the little small intervertebral muscles between each of the vertebrae. We then start adding the next layer, the intercostals, the multifidi, the quadratus lumborum, then slightly longer strap muscles that run down the vertebral column, linking those vertebrae together. Then the long intercostals, which once again are long strap-like muscles that run up the whole length of the skeletal system of the trunk, and then upper and lower serratus posterior. So we now have this, once again, a layering of muscles that actually help to link each of those segments together. I think the important thing to note here is that none of these muscles, other than psoas, cross the hip joint. So they're contained within the trunk itself. So what can your trunk muscles do? Let's have a return to our little exercise before. In this case, you're going to allow your trunks to flex again, just gently allow them to bend as much as gravity will pull your trunk into flexion. And now contract your trunk flexors as much as you can. So try and pull yourself down as far as you can into flexion. How much more do you move? Now go into extension. So once again, passively rest back into extension. And now contract your trunk extensors as hard as you can. You will move a little further, but once again, you don't keep going. There's a limit to how far you extend. Side flexion. Contract your side flexors. You go a little further, a centimetre or two, other side. Once again, maybe 2 centimetres or so, but you don't go very far. And the same for rotation. You can go passively and then try to go a little further, and you may be able to rotate a little more than you can in the other directions. But once again, it's still, you don't keep spinning around. So we have this stable structure, which has this beautiful layering of muscles to help keep everything in place and allow some movement, but not too much. Now, just stay sitting upright and squeeze your abdominal muscles as hard as you possibly can. And now you can generate a large amount of force within this cavity. And that's important too for a whole range of things. So to summarize, our trunk contains the vital organs. The muscles themselves contribute to movement, but only that movement that's permitted by that stable skeletal structure. All of the muscles are contained within the trunk, except for psoas. So what the trunk muscles can do is actually control the posture of your trunk within the trunk, but they aren't able to actually control the position of your trunk over the base of support. They can merely control the shape that your trunk can show. So they provide pressure for breathing, coughing, defecating, so on. Importantly, they're bilaterally innervated. And I'm not going to go into this in great detail because Simone described this in her lecture on strength very well. But fundamentally, our brains know that all of the vital bits are contained within the trunk, and the muscles themselves are also bilaterally innervated so that we can actually stay alive. Unlike our limbs, which are unilaterally innervated and are quite often profoundly affected when people have a stroke. But the general issue around trunk muscles is that they are essentially sustained after a stroke. So we have a skeleton that's intrinsically stable. It provides protection and containment of the vital organs. It provides attachment places for muscles, for the trunk itself, and the arms and the legs. The muscles themselves provide pressure for breathing, for coughing, vomiting, defecation, assisting with peristalsis for eating, contain and protect those vital organs. They provide movement, but that movement is constrained by the amount of range of motion that we have within the trunk. And importantly, the trunk muscles provide a linkage between our arms and our legs for forceful activities like swimming, golf, bowling, rowing, chopping wood. I'm not specifically talking about things here like arm swing for walking, because we can walk without swinging our arms. If you just think about the last time you went shopping with some shopping in either hand, you don't swing your arms around while you're walking, carrying your shopping back to the car. So it's not essential for being able to walk, but linking your legs and your arms to swim well is an important aspect because those muscles need to link together. And importantly, the muscles of the trunk are bilaterally innervated. So their extent of loss after a stroke is minimal. Now let's move on to the leg muscles. So here we have a pelvis, and importantly, the femur is a very long lever arm for those muscles to attach to. So if we start looking at the muscles in layers, we have the adductors, gluteus minimus, gluteus medius, gluteus maximus, then the large two-joint muscles, biceps femoris and semitendinosus, tensor fasciae lata. So this is a vast muscular attachment to the pelvis. If we look anteriorly, we have a similar array of muscles. Iliacus, the adductors again, psoas major, the only muscle that attaches across the pelvis to the legs. And then the two joint muscles, rectus femoris, sartorius, gracilis, tensor fasciae lata. So we now have this extensive musculature attached to a very long lever arm in the femur, which attaches to the pelvis and enables the rotation and movement of the pelvis on this long lever arm. So these muscles can all move and control the position of the trunk via the pelvis over the base of support, particularly in sitting, because they actually attach to the pelvis, and the pelvis is attached to the trunk, as we know. So trunk muscles influence the posture of the pelvis, of the posture of the trunk rather. So whether it's flexed or extended or to the side or whatever, but it doesn't affect the position of the pelvis over the base of support. Does anybody want to make any comments so far?
Karl, we do have a few questions here.
Yep.
That I've left for you from Hayley. I think it's our friend Hayley in Queensland. Do you also consider the pelvic floor as part of the trunk musculature?
Sure, it's contained within the trunk. That would certainly be part of the trunk musculature. It's not one that I've spent a lot of time considering, but certainly it's fundamental to actually containing the contents of the trunk within that structure. So yes, I would consider the pelvic floor as part of the trunk.
Okay, and the next one is, does correct breathing pattern as taught in dynamic neuromuscular stabilization, is it effective in correcting musculoskeletal problems?
That's a very good question for a PhD. I think that would be an eminent question for somebody to spend a few years of their life examining that question to actually determine whether it does or not. I'm not familiar with the with that research myself.
Yeah.
Yeah.
Sorry, I might just speak to one that came up, but I did send an answer. It was just I guess confirming that from what you were saying earlier, that when we encourage people to practice reaching outside of their base of support and things, that actually it's not really targeting the trunk muscles when we are doing that training.
Yeah, I'm finding a very long-winded way of saying that. Really what we're doing when you're training the movement of the trunk for somebody to reach, you're actually training the person to use the legs to be able to generate force to control the movement of their trunk. And we'll come back to that in some of the research that's been published. But this then leads very nicely on to the next part of this talk, which is around analysing the activity of muscles within the trunk. So here we have a very simple model, but it's fundamentally what we do when we sit and we move forwards. We have a trunk, which is about 2/3 of our body weight. It has a centre of mass, which is approximately about there, and it acts vertically. So we have our centre of gravity, which sits directly below that centre of mass. And if this centre of mass is translated forwards, then we need to do something about it. As we saw with that man who was falling to his left and forwards, he was unable to resist the demands of gravity and was falling. So we need to do something in terms of pushing to keep ourselves upright. And so over this point of rotation at the hip, which muscles do we have available to us to actually control the movement of our trunk forwards? Well, luckily for us, we've got a femur. And it's a long bone, so it can generate a large amount of force because it has this large lever arm it can use. And we have a large muscle across the hip, a number of large muscles, the gluteus maximus, medius minimus, adductors, abductors and adductors, and perhaps the hamstrings, although if the foot isn't on the ground, maybe the hamstrings don't have quite as much play if the foot is not supported. But here we now have a lever arm, which we can use to help use the leverage around the hip joint to actually stop the trunk from falling forwards or falling to the side. With your feet on the ground now, not only do you have your hip muscles, but you now have access to your knee extensors as well. And as we know, that's a really extensive musculature, medialis, intermedius, lateralis, rectus femoris, and also the plantar flexors, so gastrocnemius and soleus. So we have a very large musculature available to us now to help push to be able to control the movement of the trunk in any direction that it needs to move. So let's have a little bit of an exercise. I'm going to turn myself sideways to the camera. What you're going to do is keep your feet off the floor and reach as far forwards as you can before you start to fall off the edge of your chair. Put your feet on the floor and see how much further you can reach. So feet off the floor, how far can you go? Stay there, put your feet down on the floor and reach forwards again. So it makes quite a dramatic difference to the distance that you're actually able to reach. And the reason for that is twofold. One is you have a wider base of support to be able to control your center of mass. But more importantly, you have a very large additional number of muscles at the knee and the ankle to be able to control the movement of your trunk forwards. So having access to these muscles on long lever arms is important for us to be able to control our trunk's movement, whether we're in sitting or whether we're in standing. It's dependent upon the muscles that act across the hip to control the position of the trunk that lies above it. So trunk muscles flex, extend, side flex, and rotate the trunk. Don't cross the hip joint except for psoas. Can't stop the trunk from falling forwards because they don't act across the hip joint. So it's the one reason why people with paraplegia that have complete spinal cord lesions don't reach forwards without hanging onto their wheelchair because their legs don't work. We need our legs to be able to control our trunks as we reach. So just preoccupation with the trunk to help somebody sit is not going to help them sit because those muscles don't control the position of your trunk over your base of support. However, the leg muscles do have this very important role to play. We have large muscles, extensors, flexors, abductors, adductors, rotators, and so on. They do cross the hip joint. They can control hip flexion, extension, abduction, adduction, rotation. So now we have a musculature which can actually help to control our trunks over that base of support. So is there any questions to that?
Karl, I think it's more just for clarification. There's a couple of questions that are a bit similar, but somebody's saying, could we go over again why we can reach further when our feet are on the floor? And another person is asking, do the trunk muscles in fact influence the position of the trunk over the base of support? So I guess they're kind of a bit interrelated, those two questions, but I think maybe if you could just sort of reiterate.
Sure. I think it's important for me to clarify, what I'm not saying is that your trunk muscles don't work when you reach forwards, because patently gravity is demanding that we reach in a certain direction, and the muscles of the trunk will also work in relationship to where our center of mass is and which muscles need to contract to adjust the posture of our trunk. The important issue is which are the muscles that actually control the movement of our trunk forwards. So if I can ask you once again, that question that was asked about why can you reach further when your feet are on the ground? If I can ask you to come to the edge of your chairs so you don't have much base of support on the chair, and let your fingertips rest very gently on your quadriceps, and allow your trunks to move forwards. And come back and sit very gently. Try to find that place of balance where you don't need to use your muscles very much. And then go forwards again. So your center of mass is now in front of your hip joint. What do you feel your quadriceps muscles doing? What you are most likely to be feeling, I anticipate, is that your quads will be contracting as your center of mass moves forwards. And the further forwards your center of mass goes, the more your quads are involved in controlling your trunk coming forwards. But equally, your glutes are working also to help control your center of mass moving forwards, but they're working eccentrically because they're lengthening to control the movement of your trunk forwards. Also, having your feet on the ground means that your base of support is wider. And so that also makes you more stable to be able to reach further. So there's two things going on. One is we have more muscles available to us to push. And secondly, the base of support is wider, and therefore we have a greater capacity to move over that base of support. If your feet are really, really close to you, then that limits that base of support more to be able to then reach forwards. Does that answer those questions?
Yes, I think so. So it might just be worthwhile. There's still a question saying, is there any role of the trunk muscles in preventing fall, or only the lower limb muscles?
Preventing a fall?
Yeah, a fall. I assume a fall in sitting.
Okay. The trunk muscles will fight vainly to try and keep the trunk upright. But the problem is that they can't. So all they will do is control the movement of the posture of the bones within the trunk, but they can't actually stop the trunk from falling forwards. It's just biomechanically not possible for them to do that. So my argument here is really that people need to learn how to use their leg muscles to be able to remain upright and control their center of mass over their feet. Whether it's in sitting or whether it's in standing, the problem is the same, except that in standing, we have a much smaller base of support. And so the muscles around our feet are really important to control our center of mass moving forwards. Whereas at least in sitting, we have large muscles at our feet, knees, and hips that all can work to help control our trunk moving. Maybe if we move on and come back to some of these questions, because this leads on to this idea about the core, and English being the crazy language it is, we've got cores of all sorts of things. We've got the Earth's core, we've got an apple core, And we also have this physical core. And what sort of seems to have happened with language over the years is that core has to come to mean essential. And I would just put a big question mark next to this. And what does it actually mean? Because there is some core things that the core needs to do, but there's some really strange beliefs around the role of the core. So here's some quotes I've just taken randomly off the internet, but core stability. So here's one from the Harvard Medical School. Core stabilizes your body, allowing you to move in any direction, even on the bumpiest terrain, or stand on one spot without losing your balance. Now, what does that actually mean? It has no basis in any biomechanics at all. If you're going to walk over uneven, bumpy terrain, if your legs don't work, it doesn't matter how strong your core is, you're not going to be able to walk. I mean, it's just silly. If you're going to stand in one spot and stand on one leg, and you could try it right now, you can do it without your trunk muscles working, but you can't do it if your feet muscles don't work. If your soleus and tibialis anterior don't work, you certainly can't. Every movement you make stems from your core. Since every muscle in your body is connected to the ones in your core. Well, come on. I mean, your core is in the middle and your arms and legs are attached to it, certainly. But the core itself plays very little role in terms of standing quietly. The muscle activity in your core is almost none. You use the muscles in your core for everyday tasks like tying your shoes. This is just errant nonsense. If you're going to tie your shoes up, you bend forwards, you control your trunk flexion with your hip extensors and perhaps your knee extensors, and you use your fingers to tie up your shoelaces. You don't hold your core really tightly to help you tie your shoelaces. This is just really, really strange thinking, and it doesn't have any basis in any biomechanics or any need to control our muscle forces. So the role of the core, organ containment and protection, that's essential and it's vital, otherwise we die. Contributes to flexion, extension, side flexion, rotation, controls the posture of the trunk, provides pressure, and it links our arms and legs together in tasks such as swimming and golf. That's an important role to play. In standing, comparing young people and old people in standing, just quiet standing, the muscles that are most active in quiet standing are soleus. The muscles of the trunk extensors are slightly active, but the muscles that are primarily active in young and old are the muscles at the base of support. And I'd recommend that paper if somebody wants to go and chase up that information. So the key points so far: trunk muscles provide protection. Muscles at the base of support are the first to be activated in any task requiring self-initiated movement or balance. So in sitting, it's the thighs and the feet. In standing, it's the feet. There is one position, however, that I've found that may be where the core muscles, if you like, or the muscles of the trunk, have an essential role to play in staying upright. And that's this one. So you can see here, we have people that are, their base of support is the top of their head. So the muscles of the neck are now becoming extremely important to keep the trunk upright. And we can see here in each of these people that we can see reasonably closely that their trunk muscles are working really hard. And in this position, because the feet are now free to move around in space, the trunk muscles do have a significant role to play in maintaining the position of the pelvis so you can keep your feet in a position so you don't fall over. So here is a position where trunk muscles are essential to try to remain upright because they actually do have an influence over the position of the pelvis. But when your feet are on the ground in the other direction, they don't. All your hip flexors will do in standing is pull you forwards if you're in standing. They're not the ones that are going to pull your pelvis back into extension. So, any questions so far? By the way, I can't say that I've ever trained anybody to stand on their head.
Well, there's a very big question, Karl, but it's kind of a whole lecture in itself. It's what is the best way to retrain quads, leg muscles to control balance?
The best way?
Yeah, to retrain the quads or your leg muscles to control balance. I mean, I guess it depends on the context of the balance, I guess, too.
Yeah, I think the first place I would suggest is go back to Simone's lecture from last week to actually have a look at some of the mechanisms of strength training, looking at where the problems in terms of generating force are for this person. Does it have to do with the fact they can't generate force in the first place? And do you need to seek a position where they can begin to turn on their quads? But once somebody can begin to turn their quads on, once they have some context in which their muscles can turn on reliably, that muscle activity needs to be applied in the context of where the person needs to practice. So, for example, if it's in sitting and they're practicing reaching in sitting and they're trying to learn how to push on their left leg, for example, they need to learn when to push. So perhaps part of the training would then be around that muscle you were pushing on the end of the bed where you can get that muscle to work. Now, can you sit on the edge of the chair here? And as you come forwards, make sure you push down on the floor so you can push yourself back into the chair. So the person then learns the context of where that muscle activity needs to occur. So your question is one of, first of all, number one, can they turn their muscle on? And then number two, can they turn it on reliably? Number three, can they turn it on with sufficient force to be able to do the task they're trying to do? And then can they do it in the context of that task? So perhaps they can go forwards a little way, but they can't go very far. But you can measure how far they're able to go before their quads aren't able to return them to the upright position. So you can start to measure somebody's performance. How many times can they do it? Can they do it repetitively over a period of, say, 50 repetitions? Can they go further? Can they hold themselves at that particular point and do something while they're out in that position so they can sustain a contraction? There's any number of ways you can use your imagination to start to train muscles. First of all, to find the muscle activity, and then secondly, to put it into the context that's relevant for that person. It's a sort of long-winded answer to your question, but there's no specific one way of doing
it. Karl, I think it might just be worthwhile just speaking to this question, because I think there'd be other people asking the same. When you do have somebody with a very dense hemiplegia, and even months post ABI, how do you help them to improve their sitting balance if they've still got very, very significant leg weakness? Though again, I guess we could refer back to last week's lecture a bit in that too. But
I mean,
and I just wonder whether it's worthwhile sort of talking about some of the ways you would think about setting up the environment for somebody's sitting balance when you've got somebody who's got extreme weakness and very poor sitting balance, with maybe a wall on the intact side, and thinking about the strategies you would use.
I think they're all very relevant questions, but they're kind of beyond the confines of this lecture, because we could talk about it for hours. What I would suggest you do is come to one of the lower limb workshops if you want to, and actually we can work with stroke survivors who are weak and find ways to see if we can get their muscles to work again. But I think the big thing for me is to try, particularly for leg muscles, is to try to put them in the context in which they need to work. And sometimes putting somebody on a tilt table and giving them, if you don't have a sliding tilt table, then just use some sliding sheets behind them so they start to slip down the bed. You find the point at which they can begin to push to stop themselves from sliding down. And that's the place you start. And sometimes our brains you put the muscle in the context it needs to work in. Somehow our brains go, I remember this. I remember I need to push here so I don't fall down. Whereas doing things in open chain, for example, getting somebody to try and extend their knee in the bed, is out of the context in which the person needs to generally use their knee extensors, which is to push out of a chair, to hold our knees in extension in mid-stance, to be able to move over the foot and so on. Our knee extensors work when we're sustaining our body weight above our feet or pushing ourselves out of a chair. So to try to put muscle actions into the context, and one of the contexts is reaching and sitting. So somebody learning how to begin to reach forwards and setting them up in an environment where they can begin to practice. If I can lead on to our friend that we saw at the beginning, who was profoundly weak, and come up with, just show you just one little solution that may give you some ideas. We're now going to go on to analysis, measurement, and research. So for biomechanics, what are the implications for the analysis of movement, and in this case, in sitting? Which are the muscles that are essential for sitting? Which of the muscles are going to stop you from falling forwards? They're going to be the muscles in your legs that push on the ground to push you back up again. It doesn't matter how strong your trunk extensors are, they're not going to stop you from falling forwards. They may move your center of mass back a little bit, but they're not going to stop your hip from flexing. Which are the muscles we're going to target? It's going to be the ones that actually are weak and stop us from actually pushing ourselves back. So let's have a look at our friend again. So here he is. We've seen him before. He's falling to his left. He really has no headspace at all to think about anything other than falling over. So the person here that's doing all the work is the therapist behind him, working very carefully and very gently to try to help this man learn how to be upright, but it's just too hard. If we go back to what we've been talking about, if we watch his trunk here, just going to take the video back a tiny bit. So here she's trying to keep him upright. He's starting from this position where he's almost in a sort of upright position here. If you watch his trunk, if you take a sort of a T-piece across his shoulders and down through his trunk here, his trunk stays quite stable. His trunk doesn't do anything strange. It just stays as a block and goes sideways and forwards. And if you watch his hip, watch what happens here at his hip crease. There is nothing happening there at all. He really doesn't know how to push. Either he doesn't know or he's unable to push, has an insufficient strength to be able to push on his left leg to stop himself from falling sideways. So the fact that he's falling to his left and falling forwards, we can actually take away poor trunk control in terms of control within his trunk as being a possible cause. We can remove that biomechanically. It's not where the problem is going to lie. And doing that for this man, actually training his trunk muscles, will actually do him a disservice, because it's actually training muscles that aren't relevant for him to be able to learn how to sit. However, decreased strength in his left hip extensors, abductors, knee extensors, plantar flexors, and so on is probably a place that we need to target, as well as moving laterally. He's pushing, so he does have a decreased sense of verticality. We need to think about things to do for that. He possibly has decreased sensation, and that would influence the interventions we might use. And then the last one about not having his leg on the ground then leads back to the extensor activity in terms of being able to push on his foot to keep it on the ground. So here is an immediate, this is the same man 30 seconds later, slid across to the wall. And now look at the difference in his abilities, just at least to begin from a place where he can start to think about what he needs to do to stay upright. Now, the person behind the camera is now asking him to put his foot flat on the ground. He does that and he loses his center of mass is now not controlled and he falls away. Therapist helps him back to that upright position and asks him to think about staying next to the wall. Just going to go to that last little section here. So here he is, and now he can begin to start to try to learn how to remain upright. So he's falling, but he's falling slowly. So something is going on. Perhaps he does have a little bit of hip extensor activity, and he now has the mental capacity to be able to think about, how do I use that? How do I push next to the wall? How can I stay upright? Because now he has a clear vertical cue. He's not using his right arm to push, and he knows that that is straight, but he certainly isn't safe to leave sitting. He needs to learn how to use the muscles in his left leg to push so he stays close to the wall. That's a possible strategy you could use for somebody that actually does have problems in terms of being able to balance. And maybe they need to be supported on two sides, something next to their one side and something behind them. So they move away from something, away from the wall a little bit and back again. So they're learning how to use their trunk in a controlled way, but not having to move too far. So they're safe, they have some brain space, and they can begin to start to learn the things they need to do to begin to train the movement of their center of mass over their base of support. Do we have intervention research around decreased or absent left leg hip extensor? We do have research papers that actually show us that actually reaching and sitting makes a difference to your abilities to sit. Not only does it make a difference to your ability to sit, it makes a difference to your ability to stand up, because it approximates what you need to do as you flex your hips forwards. And if you flex your hip forwards fast, that's where you start to translate your weight from your thighs to your feet. And doing chronic training of reaching and sitting actually improves standing up. Perhaps with this decreased sense of verticality, having a strong vertical cue next to somebody helps. It's a very strong visual input that tells you when you're straight and when you're not straight. So you have this clear delineation of success versus non-success. If he has problems with his information about his sensation from his leg, then perhaps putting a defined place on the floor with some tape around it where his foot needs to be, and he needs to look at that first to understand where his foot is and to try to keep his foot there as he begins to push down on his leg. So we might need to change our intervention strategy slightly to change the information he's getting. And then this last one about his foot off the ground, as I've said, relates back up here. Well, I think what I would like to do now, instead of going straight to questions, is go on to the next bit, which is around research, and then we can tie it all together at the end. One of the problems about the research on trunk control is the research that correlates trunk control with walking outcomes, because it doesn't make sense. Training muscles within the trunk to improve your walking biomechanically does not make sense. So why? If we look at the measurement scales that are used for sitting balance, one of the ones that is commonly used, and it's in fact a very good measure of the abilities to control the trunk over the base of support, is the trunk impairment scale. The problem is it describes itself as the trunk impairment scale, and it's not the trunk impairment scale, it's the leg impairment scale. Because what this measurement scale measures is the ability of the legs to control the trunk on different bases of support and different degrees of support. And so it's not actually measuring the inability of the trunk muscles to work, it's measuring the inability of the leg muscles to control the trunk. All of the other measures are really measuring muscle activity in the legs. So it's not surprising that trunk tests are associated with successful long-term outcomes because they don't measure trunk muscle activity. They actually measure the ability to control the trunk, which is actually leg activity. So this is confusing, and no wonder we're confused when we read the research. So these assumptions about the importance of the trunk and the core and all those things will then influence what questions the researchers ask. They influence the evidence that is searched for. They influence how the evidence is perceived and interpreted. And they influence the conclusions that are drawn from that research. So if we look at a systematic review, which is in fact, I think, a really interesting systematic review, and if we just change the words slightly, it would then give clinicians a much better idea of what to do to train people to sit, to begin to stand up. So the effectiveness of trunk training on trunk control, sitting and standing balance, and mobility post-stroke, a systematic review, and it's reasonably recent, 2019. Inclusion criteria are randomized controlled trials investigating the effect of trunk exercises on mobility and balance after stroke. 22 studies, nearly 400 participants. They all involve some form of trunk training. And the results, significant treatment effect for trunk control, standing balance, and mobility. So not surprising, their conclusions were strong evidence that trunk training is able to improve trunk control, sitting and standing balance, and mobility. So when I read this first, I was thinking, trunk training can't do this. So why has this outcome occurred? So drilling down into the research a little bit more carefully, knowing what the trunk muscles can and can't do, what are the interventions that are used in these research papers? Do they train the trunk muscles exclusively, or do they train the movement of the trunk on the base of support? And what outcomes were used to actually measure these changes? Effectiveness of trunk training, trunk muscles, or training the movement of the trunk. The inclusion criteria were core stability, reaching, weight shift, so looking at weight shift, this is moving the trunk, and proprioceptive neuromuscular facilitation exercises amongst them. And here are some of the exercises that are described. So core stability, looking at trunk-specific upper and lower flexion and rotation. So this may have been specific to the trunk, but it's unclear from that particular research paper. All of the other exercises in this list, dead bug, plank, bridging particularly, because really when you're bridging and pushing your hips up into the air, your trunk doesn't need to contribute to that at all. You really do need to push perhaps with your trunk extensors a bit, but your hip extensors are primarily the exercises you're using. Sitting on unstable surfaces, once again, controlling the movement of the trunk. Weight shift in sitting, reaching exercises all involve legs. So the underlying assumptions were that trunk muscles control movement of the trunk. What we do know is that trunk muscles can control the posture of the trunk, but they cannot control the movement of the trunk over the base of support. And those trials that showed an effect on sitting, standing, and mobility all included exercises that trained the legs, i.e. the controlled movement of the trunk over the base of support, and trained leg muscles. So the false underlying assumptions then lead to false conclusions. But in fact, the conclusions of this paper are important, but they just need a bit of tweaking. So we could change the title from the effectiveness of trunk training on trunk control, sitting and standing balance, with their conclusions that strong evidence trunk training is able to improve trunk control, to this one, the effectiveness of training the movement of the trunk over the base for support to improve sitting and standing balance and walking outcomes post-stroke. The conclusion can then be strong evidence that training the movement of the trunk over the base for support improves sitting and standing balance as well as walking. Now, this then gives us as clinicians guidelines as to what we need to do about training sitting balance that may actually have longer term outcomes to improve people's abilities to sit, stand up, stand and walk, which is important. But if we just train trunk muscles, it's not going to lead to those outcomes. So we need to be coherent in the way we think. What are the biomechanics of a task? So now we have a coherent story that fits with the biomechanical demands of sitting. So the action of gravity, what the muscles of the trunk can do, what the intervention exercises included were, what the measurement tools measure. And they also, and really importantly, suggest strategies for effective interventions. And that's what we need to be able to train somebody to sit again. We now have some ideas for that man that's falling to his left about how to help him learn how to begin to push on his left leg to stay upright. Biomechanics are essential to guide understanding of muscle actions, analysis of skills, effective clinical intervention strategies. So we need to think about the essential muscles for any task or skill we're training. So in sitting, it's training the muscles which control the movement of the trunk on the base of support. Leg muscles. Strengthening trunk muscles, on the other hand, might improve your posture. You might sit a bit straighter and look a bit prettier. It might improve your swimming. Why? Because they train muscles and they train the muscles that are specific to those skills. So biomechanics, we need to understand what muscles can and cannot do. Gravity makes predictable demand on muscle actions, so we can start to use our knowledge of gravity and where it's acting to be able to think about the muscles this person needs to learn to use again and train them specifically. We need to think about the force requirements. So in the case of the video we saw, that man didn't have sufficient force to push on his leg, so therefore couldn't push himself up. So he has a profound weakness in addition to his abilities to remain upright. The interventions need to target those analysed impairments, strength, coordination of those essential muscles. And what do the measurement tools we're using, do they actually measure what the research claims to measure, or is it measuring something else? And if research doesn't seem to fit or is inconsistent with our knowledge of biomechanics, then we need to seek the reasons, because it's important that we don't just accept information on face value without thinking about it carefully and what it actually means for us. So getting back to key messages, and if there's any questions that people want to ask, I'm very happy to hang around and we can talk. Understand the biomechanics of a skill and task. Understand the role of the trunk is to protect our vital organs. Trunk muscles are bilaterally innervated, so therefore they're not significantly affected after stroke. Upright balance of the trunk is dependent upon the strength and coordination of the muscles at the base for support. So in sitting, it's the thighs and the feet. In standing, it's initially the feet. If you can't control your feet in standing, then you are going to have profound problems standing on a base of support that's unstable. And analysis and intervention strategies need to focus on the essential components of skills, such as sitting and standing. That is, the muscles of the base of support. So there's some references there. If you're going to look back over this video at the finish, then you're welcome to do that, and those references will be available to you, or you could take a very quick photo now, a screenshot. And then I might leave it open to questions.
Okay, there's a question here about, are these findings transferable to pediatric clients with low tone, in comments, who have difficulty sitting in the classroom?
Well, yes, I mean, gravity is kind of this continuous force that we need to generate strength to be able to do that. So, and there's no reason why, just because a child is closer to the ground, gravity is still demanding that they fall over unless they do something about it. And so for children, I have not worked in pediatrics particularly at all, but I distinctly remember working many years ago with a very highly skilled therapist, and her way of training children was in context to the skill. So a child that finds it difficult to sit, for example, will sit upright or remain upright, is to help them sit in a position where they need minimal muscle activity, and then just find tasks where they need to start to control their movement of their center of mass, and provides tasks that excite them and interest them or whatever, but actually mean that they have to learn how to control their center of mass. And then you can time how long they can do it for. Because to me, the implications of a child that has low tone really, to me, says that they're weak. Low tone, I don't find is helpful clinically. If somebody can't generate sufficient force against gravity, they're weak. We can measure weakness. I don't know how you measure hypotonia. So we can measure how long this child can sit for before they start to fall forwards. We can actually time that and then be able to see whether, in fact, as a result of this intervention strategy, has it improved their abilities to sit? Because gravity is not going to stop for that child. It's going to continue until they start getting bigger and taller and heavier and more difficult to control their center of mass. And so the earlier you start at giving them the opportunity to find where they minimally need to use their muscles. And we can all find a point where we can sit just where we need almost no muscle activity, and then begin to move away from that point and then come back to that point, and finding that place for that child, and then starting to move away from that and then come back to that point where they don't need so much muscle activity would be what I would be trying to do. But put it in the context of where the child needs to be.
There's a question, Karl, about truncal ataxia. Does truncal ataxia impact the muscles of the trunk or the muscles in the lower limbs? And should interventions to address sitting balance with these clients focus on the muscles as discussed in this presentation?
Oh, goodness. And ataxia is
and particularly truncal ataxia they're asking about. Yeah.
The inability to control what, and is it actually truncal ataxia, or is it ataxia of the muscles at the base of support that causes their trunk to move in all sorts of different directions? I clinically remember somebody that was a young woman, 17, 18, who had profound problems controlling movements in any direction, and particularly her abilities to be able to reach forwards, come back. And it possibly would have been described as truncal ataxia, I'm not sure. But she had profound ataxia. And the strategies that we tried for her was really to provide her with as much security to begin with as possible, and then to very gently try to move away from that sort of comfortable space with minimal demands on those changes in her center of mass. I can't say that we were very successful in her case. Ataxia is profoundly difficult, but what we do know from the limited research in this is that people need to do vast amounts of practice, like thousands and thousands and thousands of repetitions, if they're going to make a difference to their capacities to learn how to begin to modulate the force. Usually people that have ataxia are strong. Strength is not their problem. It's actually being able to control the movement of muscles on either side of a joint to be able to meaningfully change a center of mass around a joint or a point of rotation. Yeah, I don't have good answers for that, I'm afraid.